welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We have Elizabeth George, who is a PGY1 at St. Luke's, and she will be presenting a journal club on comparing the efficacy of intravenous morphine versus ibuprofen, or the combination of ibuprofen and acetaminophen in patients with closed limb fractures, which was a randomized control trial.
So there are three objectives for this presentation. One, we are going to analyze the agents used for pain management in fracture treatment. Two, we will be reviewing existing literature and assessing the need for further research on this topic. And three, we'll be examining a recent trial comparing pain management strategies in patients with closed limb fractures. So what is pain? Pain, as defined by the International Association for the Study of Pain, is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So there are numerous methods to analyze pain, but I'll be briefly going over the visual analog scale since it was utilized in the study. A visual analog scale is a tool used to measure the intensity of pain. It is a horizontal line with two descriptors at each end, usually with no pain and worst pain. The patient marks a point on the line which best represents their pain, and then the distance from the no pain end of the line is then measured to determine the pain intensity level. So fractures. A fracture is a partial or complete break in the bone. When a fracture happens, it's classified as either an open or closed fracture. So open fractures, sometimes known as compound fractures, the bone pokes through the skin and can be seen, or a deep wound exposes the bone through the skin. Whereas closed fractures, sometimes known as simple fractures, the bone is broken, but the skin is intact. As for the management of bone fractures, there are multiple strategies. You can use splints, braces, plaster casts, traction, surgery, and pain relief. I will be focusing on the pain relief portion of the management. As for pain management, there are multiple agents that can be utilized. There are local anesthetics such as lidocaine, which can be used for nerve blocks in specific fractures, such as femoral nerve block for femur fractures. There are analgesics such as non-opioids and opioids. For this presentation, I'll be focusing on acetaminophen, NSAIDs, and morphine. There are also sedatives such as nitric oxide and ketamine, which is in addition to its analgesic properties. So first, I'm going to briefly go over morphine. Like other medications in this class, morphine has an affinity for delta, kappa, and mu opioid receptors. This drug produces most of its analgesic effects by binding to the mu opioid receptor within the CNS and the peripheral nervous system. The net effect of morphine is the activation of the descending inhibitory pathways of CNS, as well as inhibition of the nociceptive afferent neurons of the PNS. As for dosage form, there are numerous dosage forms available, such as oral tablets, oral solution, rectal suppositories, IV, IM, and subcutaneous injections. The onset for oral dosage form is usually 30 to 60 minutes, while IV takes about 5 to 10 minutes, and the duration of action can be anywhere from 3 to 5 hours. And then some adverse effects are constipation, central nervous system depression, urticaria, edema, and other skin rashes. As for ibuprofen, it inhibits COX-1 and COX-2, reducing synthesis of prostaglandins responsible for pain, inflammation, and fever. Again, there are multiple dosage forms such as oral tablets, oral suspension, IV injection, and topical agents. The onset for oral is usually 30 minutes to 1 hour, while IV typically takes 10 to 15 minutes. And the duration of action is typically 4 to 6 hours. And some adverse effects, mainly the GI, are nausea, vomiting, and GI bleeding. And then there is some hesitancy in using ibuprofen in the management of pain in fractures because of the theory that it might delay healing time. So I looked into some trials. The first trial I looked at was a randomized control trial investigating the effect of ibuprofen on bone mineral density, turnover biomarkers, and callus histomorphy of Kroll's fractures. The primary outcome was difference in bone mineral density between injured and non-injured radius at 3 months post-surgery. And the key findings found that there was no significant differences in bone density, histomorphometics estimations, or biomarkers between groups. And then the authors concluded that ibuprofen may be a bone-safe analgesic for acute fracture phase treatment. And then another study I looked at involved 95 children with fractures, with 46 in the control group receiving acetaminophen and 49 in the NSAID group receiving ibuprofen. And then 6 weeks post-surgery, fracture healing was observed in 82% of the control group and 92% of the ibuprofen group. By the 10 to 12-week follow-up, 98% of the control group and 100% of the ibuprofen group had healed. So with the data from these studies, ibuprofen, especially in acute management, seems like it might not have a huge interference with healing time. And then lastly, I'm going to talk about acetaminophen. Acetaminophen has complex mechanisms that are not fully known. It has weak COX-1 and COX-2 inhibition in the peripheral tissues, and also acts at the peroxide site of the enzyme and is distinct from NSAIDs. As for its dosage forms, there are oral tablets, oral suspensions, and IV injections. Typically, the onset is 30 to 60 minutes for the oral dosage forms, while it takes about 5 to 10 minutes for the IV. And the duration of action is typically 4 to 6 hours, with adverse effects commonly being like nausea and vomiting. One major factor that led us to the study is the opioid crisis. Opioids pose a risk to all patients. Anyone taking a prescription opioid is at risk for unintentional overdose or death and can become addicted regardless of their race or gender. In 2022, nearly 9 million Americans reported misusing prescription opioids in the past year. And then from 1999 to 2022, nearly 300,000 people died from overdose involving prescription opioids in the United States. So these graphs depict the increase in deaths due to overdose with opioids and really emphasize the need for change. And looking at existing literature, one study looked at the oral administration of morphine versus ibuprofen to manage post-fracture pain in children. So the purpose of the study was to assess whether orally administered morphine has superior efficacy compared to ibuprofen for pain related to fractures. The design was a parallel group randomized blind superiority design trial. The population were children aged 15 to 17 who presented to the pediatric emergency department with non-operative radiographically evident extremity fractures sustained within 24 hours. And patients were excluded if they had a known hypersensitivity to either ibuprofen or morphine, chronic use of NSAIDs or opioids, associated injuries requiring analgesia, known renal disease, bleeding disorders, and pregnancy. And then for the intervention, patients were randomly assigned to either receive morphine every 6 hours or ibuprofen. And in conclusion, the authors found that there were no significant differences in the analgesic effect between the orally administered morphine and ibuprofen, and that there were more adverse effects associated with the morphine. And then the next trial I looked at the common analgesics for the treatment of acute pain for children, and it was a systematic review. So the purpose of this trial was to compare the safety profiles of acetaminophen, NSAIDs, and opioids in the management of acute non-surgical pain for children less than 18. And the study design involved children experiencing acute pain and treated in the ambulatory care setting, where pain medications included acetaminophen, NSAIDs, and opioids. And then any patients who needed surgery due to the pain were excluded. And in conclusion, the authors found that ibuprofen was as effective as a combination of acetaminophen and codeine. And they also found that both ibuprofen and acetaminophen have similar reported side effects, and they have fewer adverse effects when compared to opioids. Now I'll be getting into our trial. This trial is going to be comparing the efficacy of intravenous morphine versus ibuprofen, or the combination of ibuprofen and acetaminophen in patients with closed limb fractures. As for the purpose and design, the objective of this trial was to evaluate the effectiveness of intravenous ibuprofen or intravenous ibuprofen combined with acetaminophen in comparison with intravenous morphine in patients with closed extremity fractures. And as for the study design, it was a triple-blinded randomized clinical trial that was conducted in a tertiary trauma center in Iran. As for the population, the inclusion criteria included adults between the ages of 15 and 60 who had closed limb fractures and had a pain intensity that was at least a 6 out of 10 on the VAS scale. And the exclusion criteria was very extensive. It excluded any patient with respiratory or hemodynamic or neurological problems, analgesia due to 6 hours prior to the ED arrival, routine analgesic use because of chronic pain, renal or hepatic failure, allergy to the study drug, history of a GI bleed, lung disease, if they had a head trauma, drug abuse, if they're unable to explain their pain, if they're pregnant, concurrent neurovascular damage, multiple fractures, other pain hiding fracture pain, or if they require surgery for treatment of their fracture. As for the intervention, so ice compression, limb immobilization, and evaluation was done for all patients. And then there were three intervention groups within the study. The first group was the ibuprofen group, where they received 800 milligrams of ibuprofen in 100 mLs of normal saline for 15 minutes and 5 mLs of normal saline for 5 minutes intravenously. The second group was the ibuprofen acetaminophen combination group, where they received 400 milligrams of ibuprofen plus 1 gram of acetaminophen in 100 mLs of normal saline for 15 minutes and 5 mLs of saline for 5 minutes. And then the last group was the morphine group, where they received 100 mLs of normal saline for 15 minutes and 0.1 milligrams per kilogram of morphine sulfate, increasing the volume to 5 ml with normal saline for 5 minutes intravenously. As for the outcome, the primary outcome assessed was the reduction in pain score of the groups after 1 hour from injection. As for the statistical analysis, the sample size was determined based on minimum clinical significant mean of 1.3 point between the groups. So this was required. So then the sample size was calculated to be 50 patients per group. And then to also account for potential error, 10% adjustment was applied, so resulting in a sample size of 55 patients per group. And then the power of the study in alpha group were 80% and 0.05 respectively. And some statistical tests utilized were the independent sample T, pair sample T, one-way ANOVA, and chi-square test. As for the baseline characteristics, 388 patients were evaluated and 158 were ultimately analyzed because the rest of them did not meet the inclusion criteria. And then looking at the baseline characteristics, two things I did want to point out are the sex and age. 35% of the patients were female, meaning that majority of the patients included in the study were male. And then looking at the age, across all three groups, most of the patients were in their mid to early 30s. And then looking at the primary outcome, so the focus of this table is on the reduction of the pain scores rather than the baseline pain levels. So the results indicate that 1 hour after injection, the acetaminophen ibuprofen group exhibited a significantly greater reduction in pain scores compared to the ibuprofen group. Additionally, the ibuprofen group showed a greater reduction in pain scores compared to the morphine group. The table also reveals the time intervals at which the most significant reduction in pain scores occurred. So that was 15 minutes after injection in the morphine group, 30 minutes after injection in the ibuprofen group, and then 1 hour after injection in the acetaminophen ibuprofen group. This graph kind of visually depicts the table from the previous slide. Here it's kind of easier to see that morphine had the quickest reduction in pain, but it was not sustained after the first 15 minutes. And then ibuprofen and acetaminophen combination, as seen in gray, had the slowest onset of pain relief, but it was sustained over 1 hour and overall produced the most pain relief. Another thing I wanted to point out is the potential ceiling cap that can be observed with the ibuprofen group. There are numerous studies stating that there are no differences in pain scores at 60 minutes between 400 milligrams, 600 milligrams, and 800 milligram doses of ibuprofen. Here, the ibuprofen group, which can be seen in orange, received 800 milligram dose of ibuprofen, while the acetaminophen and ibuprofen combination group received 400 milligrams of ibuprofen along with 1 gram of acetaminophen. So maybe the lack of the greater difference in pain in the ibuprofen group by itself could be due to the ceiling cap, as well as the ibuprofen acetaminophen group having a combination of mechanisms. For the authors' conclusions, they concluded that ibuprofen, both alone and in combination with acetaminophen, demonstrated greater effectiveness than morphine 1 hour post-administration and provided longer duration of an analgesic effect. They also concluded that further research is required to evaluate the long-term safety and efficacy of these non-opioid alternatives, as well as their practical implementation in the ED. So for some strengths and limitations, One major strength was that this was a triple-blinded randomized clinical trial, and the authors did a great job in their interventions and making sure that it was actually blinded. Another strength was that it was adequately powered, and there was also proper follow-up during the 1 hour time interval. And the exclusion criteria was extensive enough to effectively rule out any contraindications to the medications or any bleeds. And then some limitations were that the duration of pain control was limited to 1 hour. In the ED, pain control and a patient's time in the ED may not just be limited to 1 hour. So there is no data on pain management after this initial hour. And there's also no data on outpatient management of pain because oftentimes these patients will require some medications on discharge for management of their pain. And then another limitation was that the study is only applicable to a very small population. It excluded pediatric patients, and then the study also predominantly consisted of males. So this also makes it hard to extrapolate the data for geriatric population who might be coming in with falls and a fracture due to the fall in the ED. The exclusion of patients who use analgesia 6 hours prior to admission was also a limitation because oftentimes in real practice, patients will use a medication like ibuprofen or Tylenol prior to their ED visit to help manage their pain until they get into the hospital. And then another limitation, especially a site-wide limitation, is that institution-wide limitation is that at least here at St. Luke's, we do not have ibuprofen on formulary. And so it would depend on if other institutions do have this on formulary to see if they can extrapolate the results of the study to their specific institutions. And as for the clinical relevance, this trial further confirms and promotes the use of non-opioid medications in the setting of acute pain related to closed limb fractures. The data from the study is only applicable to a very small patient population, which limits the generalizability of the data. And the morphine showed the quickest reduction in pain. However, pain control is sustained with a combination of ibuprofen and acetaminophen. So overall, clinicians should use a multimodal pain management strategy and use individual patient factors to aid their decision on what agents to utilize. These are the references, and I'll take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.